Hello, I'm David Cashen, an orthopedic surgeon at Coastal Orthopedics in Bradenton and Sarasota, Florida. Thank you for your time. I'd like to talk to you today about rapid recovery anterior hip replacement surgery. The game plan today is for me to go over a little bit about what hip arthritis is, how it may affect your life, how it may limit your activities. I also want to talk about the traditional standard hip replacement surgery, and I'm going to focus mostly on anterior hip replacement surgery, why it's possibly a better approach, and the benefits of the anterior hip replacement. And then I'm going to go over what determines successful hip replacement surgery. So if you come into my clinic and this is what your x-ray looks like, you're probably in the wrong clinic, because this is a normal hip x-ray. We see a ball and then the socket up here, and we see a space between the hip and the socket there. That space has cartilage in it. That cartilage is smoother than two pieces of ice rubbing over each other. So there, you're not going to feel that hip. That's going to be a 20-year-old's hip. As things get worse and you have this x-ray down here and there's no joint space, you're going to have significant pain. You're going to notice that you have pain particularly in the front of your hip, in the groin region, and you may have difficulty with certain activities such as walking or standing. You may only be able to shop for a few minutes at a time, and oftentimes you have nighttime pain. With the hip, also you notice limitations. You may be stiff, you may have difficulty putting on your shoes and socks, you may notice that you're limping, and that you require a cane to walk long distances. So here again is that normal x-ray here on the left, and here's the abnormal x-ray. You see here that space between the ball and the socket has disappeared. You now have bone-on-bone arthritis, and that's going to cause some significant discomfort. Treatment options for hip replacement surgery begin kind of naturally. If you start to have significant pain, you limit what you do. You don't walk as far, you wear flip-flops instead of shoes because you can't put your shoes and socks on. And then you can get down to medical therapy. Typically people try ibuprofen, they try Advil, they try Celebrex. These medications can help you, but there are also some problems with those medications. You can develop ulcers with ibuprofen, you can develop kidney trouble, so you have to be careful with these medications, and they'll only work for so much time. Physical therapy has been shown to be helpful to delay hip replacement surgery in folks with more mild or moderate arthritis, and so we often try that early on in the process. Hip injections have a role. Typically we try steroid injections. These injections can help us determine whether or not this is a hip or a back problem, and sometimes they can be therapeutic, giving you 3 to 4 months of relief. More controversial are stem cell injections and PRP injections. This is something I won't get much into today, but sometimes they can try to put off your surgery as well. And now I'll get into the surgical treatment options. So the gold standard is a hip replacement surgery. We've done hip replacements since the 1960s. We have over 50 years of experience. The success rate of this operation approaches 90% of the time. The hip implant's surviving to 20 years. And so the next slide will show a little bit about what a hip replacement is. Now this is just a diagram showing the pelvis, and this is your thigh bone or the femur, and this is the hip replacement. We have a socket, and then we have a stem that you can't see quite here, but it goes into the bone, but you can appreciate that on the x-ray where you see this implant here going into the femur. This is actually the first hip replacement I ever did, and that was back in 2008. And this is the socket. This is a metal socket. It's a titanium socket. This back then was a metal ball. We now use a ceramic ball. So this is another schematic to kind of show you what a hip replacement is. So today's standards are uncemented. We pretty much avoid cement unless you have very bad bone or osteoporosis. Ceramic balls, it's actually a pink ball. So men, you get a pink ball too. That's a ceramic ball. This is a titanium stem, and this is a titanium socket. We call that the acetabular component. And there's a piece of plastic that fits inside that socket. You can see it barely there, and that's the 4 parts to a hip replacement. Now current trends, and I'll focus on anterior hip replacement surgery, but there's also a current trend towards robotics and typically navigation. I use a navigation system which helps me map out your surgery live during your surgery to make sure I can recreate your anatomy and make your leg lengths the same length. The anterior hip replacement surgery, the approach has been around forever. Smith Peterson described it in the 1930s. He was a very well-known surgeon at Mass General Hospital, where I was an intern and trained at Harvard. And then Joel Mata out in California kind of developed this modern technique about 20 years ago. This surgery, you're lying flat on your back, and the incision's actually in the front of the hip. That's why we call it the anterior hip replacement. So the incision's up in front, not towards the buttock, or what we call the posterior approach. This is my favorite slide because this really explains what we do with an anterior approach. And I'm going to focus right here. This is a cross-section of your hip. So it's right across in this direction. So to give you some reference, your belly button's here, your buttocks is here, and this is the inner part of the pelvis. This is the outside. So the anterior approach comes between the muscles. This is the sartorius and the hip flexors, and this is called the tensor fascia lata. So we don't cut muscle, we don't even split muscle. We just go in between the muscle to get down to the hip joint. On the posterior approach, which is the standard way to do things, you come in this direction. In that approach, you have to split this muscle here. That's the gluteus maximus muscle. Everybody knows that muscle. That's one of the biggest muscles in your body. So you have to split that muscle, and then you have to release these smaller muscles. These are the external rotators to your hip. Now later on, we repair these muscles, and this will heal back, but you have to split muscle, so it's a bit more traumatic. The other thing is the sciatic nerve is in your way here, and when we go through the front, the femoral nerve is further out of the way, so we tend to see less nerve damage when we go through the front. So the pros to the anterior approach, or what the benefits are faster recovery. I'll go through the dislocation risk through anterior approach, but it's much lower in that way. And often you have less pain. The downside to the anterior approach, and probably why not every surgeon does the anterior approach, is it's technically more difficult. There's technically more chance of some complications during surgery, and that can be eliminated once you get through your learning curve. So like anything you do in life, if you do something a few times, you get better at it. Well, with anterior hip replacement surgery, most studies have shown you at least need to do 20 hips to improve your success rate, and even some studies show that you should do 100. I've been doing it since 2009, well into the thousands, so I think I'm past the learning curve, but this is an operation that isn't for every surgeon. And you also want to do quite a few of them a year. 80% of the hips I do through the anterior approach, and that approach is probably 200 to 250 hip replacements a year. So the benefits is it's less traumatic, as I described in that one cross-section photograph or cartoon. It's a smaller incision. Initially, when you're learning, it's not, but now it's a smaller incision. It's about a 10-centimeter incision. It often leads to less pain. That means you're using less narcotics, and it often leads to a faster recovery. One of my favorite things is the no restrictions after surgery. So when you have a traditional posterior approach surgery, we have to tell you to avoid bending your hip past 90 degrees, avoid rotating your hip inward or crossing your hip across your body so you don't have a dislocation. So these restrictions with an anterior approach, we don't give to patients. You have no restrictions. You can involve and be involved with activities such as yoga, Pilates. The dislocation rate is so low, it's about 1 in 200. Some studies there are no dislocations. Additionally, for me as a surgeon, during surgery, I get x-rays, live x-rays and navigation, so I know exactly what I'm doing. There's no surprises. I know where I'm putting your hip. I know that I'm doing a much better job with your leg lengths. So again, the faster recovery comes from less trauma to your body, so there's less pain. We often send people home the same day of surgery or possibly the next day. You're off of a walker faster, you're on a cane for about 2 weeks, and you can get back to normal activities sooner. Now each patient is different. So I said that I do about 80% of my cases through an anterior approach. Some patients, they may have severe osteoporosis, so I will use a traditional approach because I'm afraid of a complication. so I will use cement, and we utilize that through a more traditional approach. Some patients with bad lower back pathology or lumbar stenosis, or if they've had previous back surgery, do better with an anterior approach because the dislocation rate can be quite high with the posterior approach. So in other words, when I see my patients, we have a discussion with which operation I think will work best for them. Bottom line, no matter what hip replacement you have, through the front or through the back, you're going to do well. 98% of patients rate that their pain goes away. Hip implants are surviving 90% of the time over 20 years, and patient satisfaction rates are extremely high. What determines your success, a lot of patients come to me and say, what type of implant are you putting in my hip? And actually, probably the most important thing is your surgeon. What is their experience? Are they fellowship trained? How many hip replacements do they do a year? What are their complication rates? What are their infection rates? These are the kind of questions you have to ask your surgeon. By watching this video, you're educating yourself. The more you know about hip replacement surgery, the more you're prepared to do the work to make it work for you. We do a great job with pain control nowadays. We use spinal anesthetics, we use blocks, we use a lot of medications to limit the need for narcotics, and that leads to a rapid discharge home. Postoperative care is all about getting up and moving around. As we get patients out of bed right away, as we get them home from the hospital, either the day of surgery or the day after, patients have less complications. They're not getting blood clots as much as we used to, and we're seeing lower infection rates. So we want you home, we want you comfortable as soon as possible. So with a hip replacement surgery through an anterior approach, you can expect to walk the day of surgery. You can even plan to go home that day, maybe the next day. You'll be off of a walker in less than a week. You'll be using a cane for about 2 weeks. You'll be able to drive in 4 weeks. Low impact activities such as walking 2 to 4 weeks, and higher impact activities such as golf and tennis by at least 3 months. Thank you very much for your time. I hope this is very informative for you. I'd be happy to answer any questions. You can call to make an appointment at Coastal Orthopedics. Thank you for your time.